You are now listening to Nailed It, the Orthopedic Surgery Podcast.
Dr. O'Brien, welcome to the Nailed It Ortho Podcast. So happy to have you. Welcome to the podcast.
Thank you so much. It is a real honor to be here. I've been a big fan for years. Cody and I go way back. So he trained orthopedic residency at Tulane. So we've known each other for years. So this is a real honor for me, Cody. Thanks for having me.
Oh, no, honor for me having you on. I'm like, yes. Again, I've really been looking forward to having you on the podcast. So I'm so happy that we finally have you here. And I know a lot about you, but the people listening may not know as much about you. We always start off just a couple of questions, just getting to know you a little bit better. So the age-old question, because we have some residents that listen to this, maybe even some third, fourth-year residents that are trying to decide what they want to do. And so I always ask a question, or sometimes I ask, what's one of the things that drove you more towards, I guess, shoulder and elbow now, of what you basically do? So what made you kind of choose this specialty?
Yeah, I really liked the variety of the things that we get to treat. So coming into residency, I figured I would do sports medicine. And then I was at University of Maryland, so had great mentors there. So Anand Murthy was our shoulder surgeon, Craig Bennett and Jamie Drees were our knee surgeons. So we had a great training, great experience there. And through the rotations, I really liked the shoulder procedures more. So I liked being able to do arthroscopy, arthroplasty, fractures, ligament reconstructions, tendon transfers. And so in one day in the OR, we were doing 5 or 6 different variety of cases. And so it just turned out I had more fun with the shoulder stuff than the knee stuff. And I wasn't really trained in hip arthroscopy at all in residency. So the variety of the cases really kind of piqued my interest. And then same with sports medicine. It's like dealing with young, active people that are motivated to get better, and seeing those folks get back on the field and do everything they want to do is what makes your day the best.
Yeah, I can attest to that, especially just even training Tulane and looking at the schedule for the day. You may have it's like you just said, shoulder arthroplasty, cuff repair, labral reconstruction, or labral repair. I enjoy shoulder and the breadth of cases. You can AC reconstruction, CC reconstruction. There's a lot you can do.
And then clavicle fractures, humerus fractures, elbow fractures, arthroplasty. Now we're doing more lower trap tendon transfers. So it makes for a fun day.
Yeah, those are really good cases. And the next question that we have for you is, a lot of people are, again, looking into practice. We maybe have some fellows that are listening in on this and trying to decide what kind of practice they want to join. And so what kind of drove you towards more academics, or maybe private-demics? I don't know what you call it, but what brought you towards this more the academic route?
Yeah. And so at Tulane, we're an academic institution, but it functions like private-demics, where we each run our own clinics and we're seeing patients and doing surgery, and we get the honor and benefit of working with residents and some sports fellows. But our practice runs independently. So what really did it for me, when I came out, I wanted to do shoulder and elbow. So I did a shoulder and elbow fellowship at Rothman and really wanted to try and focus primarily on shoulder and elbow. And so I found out that most of the private practices said, okay, well, you're going to start out as a general guy, and then you can work towards building your practice over 5 to 7 years. But that would have included probably some total knees and a lot of knee scopes and general fractures and stuff. And at Tulane, I was fortunate to have the opportunity to train and work with Buddy Savoie, world-renowned shoulder and elbow surgeon, to learn from him and also do primarily shoulder and elbow stuff. And so working with residents and med students was a big interest of mine. I've never been a prolific researcher, so it doesn't come naturally to me. So I have to work at the research a little bit, but working with residents and fellows, because y'all keep us on our toes, because you're looking at the latest studies and you'll say, hey, what'd you think about this article? And I'll say, I don't know, Cody, what'd you think about this article?
Right.
And I have to go home and read it that night. But
right.
What really drove the decision for me was to really be able to focus on shoulder and elbow, and also the ability to work with and train residents.
Yeah, I've heard a lot of people say the same thing, especially about keeping you on your toes and staying up to date with research. For those that are listening that are trying to decide, hopefully this can give you some tidbits or maybe a push one way or another. And in the last one, the left field question, or any interest that you have outside the field of orthopedics. It can be anything. It can be ski, whatever you like to do.
Yeah. Sports, pretty much. Love Tulane football, love the Saints. I'm also a Vikings fan. I grew up in Minnesota, so that tortures me a little bit every year with the Vikings. So we go to a lot of sports games. And right now, I've got two girls that are 14 and 11. So a lot of our stuff on the weekends is around their schedules with cross country and lacrosse and stuff like that. I like to get a little duck hunting in the winter seasons. In the summer months, we love to travel. So whenever we can, we'll try and go. We do a family trip every year, whether it's around the US or something. We haven't taken the kids to Europe yet, but that's on the radar for the next couple of years. So I think travel, good restaurants, sporting events, that makes me happy.
Yeah. And those are, I can say, also make me happy as well. Those are all fun things to do. I don't have any daughters.
I don't do anything crazy. So it's all simple stuff.
Oh, perfect. Let's go ahead and transition and get into the topic of today. And we're going to talk a little bit about elbow arthritis. And just to give just a little bit of background of elbow arthritis, what are some of the things that can cause patients to come to the clinic with, what are some of the causes of elbow arthritis? And then we can go through each one of these individually.
Yeah. So I think the most common things that you're going to see are still osteoarthritis and post-traumatic arthritis. Now with disease modifying agents and DMARDs, we're seeing less of the inflammatory arthropathies. So we see a little bit less of rheumatoid arthritis, psoriatic arthritis, lupus, things like that. So the most common things that I see are usually run-of-the-mill osteoarthritis and then post-traumatic arthritis. So we've got excellent trauma colleagues down here that fix broken elbows after bad trauma at our level 1 trauma center. And they'll often come in. Yeah, there we go. So with post-traumatic arthritis, our guys are great at putting broken elbows back together. And then it's really common for those to get stiff. And so once the fracture heals, even with early motion, a lot of times they'll lose their terminal flexion and extension. So then we work with our trauma guys on those once they've been through rehab and they kind of get stuck and they're not progressing. And sometimes we'll take some of the hardware out, sometimes we'll leave it in, but that works great to scope the elbow, to clean out the scar tissue. You can release the ulnar nerve open, and then you can go in with a scope, anterior and posterior, resect all that scar tissue to get them moving, and then get them right back into physical therapy. And usually you can get them at least a functional range of motion, hopefully near full range of motion with that. I think the other big category that we see a lot of is just osteoarthritis. I should have started with that when it was at the top.
No, go for it.
So that one, usually folks come in with a loss of motion. And so they'll come in because they'll say, I can't extend my elbow all the way anymore. I have trouble getting my hand to my mouth. And they don't have as much pain. They have kind of a painless arc of motion through a functional motion, but they lose that terminal flexion and extension. That's from those impinging osteophytes that form on the tip of the olecranon and the olecranon fossa, or then in the front on the tip of the coronoid and the coronoid fossa. And so that one, you can usually tell on exam because they'll have a pretty firm endpoint to flexion and extension with a relatively painless arc of motion in the middle. And it's fine to live with that until they can't. And they'll decide, well, now I really have trouble getting my hand to my mouth, or I can't get a phone to my ear, or I can't extend all the way. So if they exercise, that gets in the way. And they'll typically put up with that until that loss of motion really starts to affect the things they enjoy or their quality of life. And then we'll get a CT scan of their elbow to map out the osteophytes. And an arthroscopic debridement works great for that. So you can go in the front, clean out the coronoid fossa, shave away the coronoid osteophytes, go to the back, clean out the olecranon fossa, shave away the olecranon osteophytes, and you can usually get them back a full range of motion. And so that's a pretty minimally invasive procedure that restores their normal anatomy, but gets them back to doing everything they want to do.
Yeah. And so kind of just to summarize it, so you spoke about post-traumatic arthritis, which are patients that have unfortunately sustained maybe some distal humerus fracture, some elbow fracture, radial head, something where they have undergone surgery and now they become stiff and therefore they've developed arthritis. And typically with those, you can treat those arthroscopically, like you were talking about, and doing arthroscopically releasing some of those contractures and maybe doing an ulnar nerve transposition or ulnar nerve release. And then you also talked about some primary arthritis. And the main thing with that, as far as physical exam, was that they typically have a painless arc of motion, but at the terminal of flexion and extension, it's like kind of a hard stop. And so what x-rays do you typically get? Like, what are your, they come to the clinic and they say, oh, my elbow hurts, and you take a look at it and you see those hard stops in motion. What x-rays are you typically getting? Do you have a series that you normally get? And I know you mentioned a little bit about where some of the osteophytes are, but what exactly are you looking for?
Yeah, so we'll get an AP, a lateral, and then we'll get two obliques. So kind of a internal rotation oblique and external rotation oblique. So you can use that. On the AP, I want to mainly look at their joint space. So I want to look at the ulnohumeral joint and the radiocapitellar joint. And I want to see that if they have a maintained joint space or if the joint space is obliterated. And then the other thing I want to look at is just, do they have a normal joint architecture? Does it still look like a humerus, a radius, and an ulna? Or is it so degenerative that you can't really make out the normal contour of those bones? Some of the obliques, one oblique, like the external rotation oblique, is going to give you a better look at the radiocapitellar joint. The internal rotation oblique shows you a little bit better the tip of the coronoid or osteophytes on the medial coronoid. And then on the lateral x-ray, like on the right, to know that you've got a good lateral, you really want to see that nice hourglass of the distal humerus. So you see the cortex of the shaft, and then it comes together very narrow at the coronoid fossa and olecranon fossa. And then the spool of the distal humerus should look almost like a circle right there, like you're outlining. The radial head should be pointing at the center of the capitellum on every view. So if you see the radial head is dropped out the back or subluxated posterior or lateral, then you know that there's some damage to the lateral collateral ligament complex. And that can happen after trauma. That can happen after an inflammatory arthropathy like rheumatoid arthritis, where they get this big synovitis and it just causes incompetence of those collateral ligaments.
Go ahead.
One real quick, Cody. Mm-hmm. And then on the lateral x-ray, I look at the tip of the coronoid and the tip of the olecranon right there. And so you can start to see some spurring that can form on the tip of the coronoid in the front or the tip of the olecranon in the back. And that can give you some idea about, is there bony impingement that's really blocking their motion?
Yep. Perfect. I love that overview. And since you had mentioned rheumatoid arthritis, I know you mentioned it earlier. You said that you're not seeing this as often because now of all the DMARDs and the medical treatment of rheumatoid arthritis, that you're not seeing rheumatoid or inflammatory arthritis as often. But say, for example, you're taking your boards or your OITs and they love to ask this, or you're in a country where they may not have access to a lot of medications. What are just some of the quick high points on inflammatory arthritis that we should know?
Yeah. So usually with inflammatory arthritis, usually the patients already have a diagnosis when they come in. So they'll have a diagnosis of rheumatoid arthritis or psoriatic arthritis, lupus, things like that. As you said, luckily with the medical management of those diseases, luckily we see these chronic destructive changes less. They'll usually come in with more constant achy pain, and it's from the synovitis in their elbow. They won't lose as much motion typically as osteoarthritis. They may have a full maintained range of motion, but they'll be more painful throughout that entire motion. And then they're usually going to have kind of this boggy synovitis. So as you palpate that lateral gutter and the radial head on the lateral gutter, they're going to have tenderness there and kind of this boggy synovitis. They might have it on the medial side too, but you usually feel it down that lateral gutter. They tend to have a higher incidence of ulnar nerve subluxation. And so you want to keep your finger on the medial epicondyle as you flex and extend, and just make sure that ulnar nerve isn't subluxating out of the groove. And so if they have pretty good maintained motion, and we'll get to the x-rays in a sec, then we might start with a cortisone shot and some therapy. When they start to get more destructive changes, then you might have to do something a little more aggressive. So if you look at these x-rays, this is definitely characteristic of inflammatory arthropathy or rheumatoid arthritis. So that lateral x-ray is the classic pencil in cup. So you can see how you've got these periarticular erosions, you have diffuse osteopenia, you don't see the sclerosis or the osteophytes that you see with primary arthritis. And on that lateral x-ray, the humerus tapers down and you don't really see the spool of the distal humerus. It just comes down to this point. And then that greater sigmoid notch of the ulna is widened out. So it looks like a pencil in a cup. So once you see that pencil in cup deformity, that's classic for inflammatory arthritis or like rheumatoid arthritis. And a lot of times on the AP, you'll see diffuse osteopenia. You'll see pretty concentric joint space narrowing. You'll see a lot of periarticular erosions and cysts. So you won't see the osteophytes that you see in primary arthritis, but more of this diffuse osteopenia, and almost looks like the bone is starting to melt away.
Yeah, that's a good way to put it. I remember every time I would see one of these x-rays when I was studying or anything, you'd say, oh, this does not look normal. If you compare it, for those studying, compare inflammatory arthritis x-rays next to primary arthritis x-rays, and you'll see all those changes like you were just talking about, like the periarticular erosions, a lot of cysts, et cetera, et cetera.
Yeah, and a lot of that is from the inflammatory nature of the disease process. So they get this rip-roar and synovitis. And so they have synovial hypertrophy, which causes a lot of swelling, causes the joint to kind of balloon out. That can cause incompetence of the medial and lateral collateral ligaments. So they're more likely to go on to have instability with an inflammatory arthropathy. That causes loss and destruction of the cartilage, loss of the joint space, and those periarticular erosions. And one thing we see a lot down here is hemophiliac arthritis. And Tulane has a hemophilia center, so we get referred in a lot of hemophiliacs. And when their elbows, their target joint, they get these recurrent bleeds that causes a reactive synovitis and those hemosiderin deposits that destroy the cartilage. So the hemophiliac arthritis looks a lot like rheumatoid arthritis with those kind of same radiographic characteristics.
Yeah, perfect. Great explanation. And so you went over some of the treatment options, and we mentioned that some of them differ depending on the etiology of the arthritis. So say, for example, I guess we'll just quickly go over primary arthritis. Like how often, because you mentioned steroid injections, how often would you do steroid injections, activity modifications, and then we can kind of go into the operative treatment options.
Yeah. So I think with primary osteoarthritis, depends on their pain and how much motion they're lacking. And so if they are just missing 10 or 15 degrees of flexion and extension, and they're not having too much pain, then we might try some oral anti-inflammatory medications, physical therapy. We can still try. One thing too is if they have a softer endpoint where they hit here, but you can still kind of stretch them a little bit, that might be some capsular contracture contributing. And so then we could do an intra-articular injection and put them in physical therapy for some range of motion and stretching. That works great for the post-traumatic arthritis if you're catching it early. So if they still have kind of a soft endpoint, and if you're pushing, you can extend them or get a little bit of motion back, then physical therapy can help. Bracing can help. So like the turnbuckle orthosis, turnbuckle brace, or like a Dynasplint, which is kind of spring-based. I like the turnbuckle ones. There's one called a JAS brace, JAS. It stands for Joint Activation System. We have no affiliation with either of these companies, but those, it's like a turnbuckle where you crank on it as far as they can, and then they can crank it a little bit more, and they're in control of it. So on a good day, they can crank it a little harder. On a bad day, they don't crank it as less. The Dynasplints are good too. Those are more kind of spring-based, which gives it just a constant push in one direction, and you can get it for flexion or extension. When they have a really firm endpoint, or if it's been going on for a long time and they're missing a lot of motion, so if they can only flex to 90 degrees and they can't get their hand anywhere near their mouth, and if it's post-traumatic, they've usually already had physical therapy and those things. When they've got a greater loss of motion and it's really affecting their quality of life, that's when we'll start to think more about surgical treatment of that. I think similar for the inflammatory ones, if you go back to your classification slides, when it's low grade, go to the Larson classification. There you go. So when you look at these grading systems, when it's more low grade where they still have a normal joint architecture, then I think a cortisone shot to try and calm it down and physical therapy to regain some motion. Sometimes you might put them on a short course of an oral steroid, make sure that their disease modifying agents are up to date. When it's grade 0 or 1, I'll try an injection with some physical therapy. Once they get into grade 2 and 3, but they still have a pretty normal joint architecture, that's where I think arthroscopic debridement works great, which we'll get into next. Once they really get into gross deformity, so like grade 4 and 5, and the joint is really destroyed, that's usually where they have pain throughout the range of motion. They might have developed some instability at that point. And that's when we would think about more reconstructive options. So if they're younger, possibly an interposition arthroplasty. If they're older, meaning 60 or older, then probably total elbow arthroplasty.
Perfect. That was great. And so now I think we can dive a little bit deeper into these operative treatment options. Because I remember, especially when we were studying for our board exams, it was never as simple as those non-operative versus operative. It was operative, and then they made you choose between the different procedures. You're like, man, I thought I knew this, but I guess I don't.
Right.
So can we kind of go through some?
Never easy questions on the board.
No, never. No dunks, no alley-oops. You just gotta go. Can we kind of go through some of these?
Do is for osteoarthritis and post-traumatic arthritis, you're usually going to see those in younger folks. So arthroscopic debridement with osteocapsular arthroplasty works great. So osteocapsular arthroplasty means you're going to go in with the scope, you're going to shave away the bone spurs, you're going to release the capsule, you're going to do a synovectomy to help get rid of that synovium. And it's the bone spurs that are impinging that are blocking their motion. So once you clearly identify the bone spurs on your 3D CT, and then you can go in and you clean out the coronoid fossa, shave away the coronoid osteophyte, go to the back, clean out the olecranon fossa, shave away the olecranon osteophyte, that usually gains significant motion. If they're still stiff, then you can also do a capsular release at the same time. One thing to keep in mind is if they can't flex past 90 degrees, actively or passively, then you really need to do an ulnar nerve release at the same time. If you don't, the nerve gets tethered in the groove, and then as they start to regain flexion, they get a tardy ulnar nerve palsy. So they can get pain and numbness in the ulnar nerve distribution. They can get atrophy of their hands. So if they've got a flexion contracture to 90 degrees and you can't flex past that, release the ulnar nerve. I do the ulnar nerve first and then go in with the scope and clean everything out. In the setting of inflammatory arthropathy like rheumatoid, it's usually the synovitis. And so if you can go in, even if their joint space is obliterated, they still have a normal architecture, but they have no joint space. Then we go in with the scope and we just do a complete synovectomy. Oftentimes they'll have good motion, so you might not even have to do a full capsular release. You just do a full synovectomy. The tricky part is you got to get down the medial and lateral gutters. So there, I'll do an open ulnar nerve decompression to actually put a vessel loop around the nerve to pull it out of the joint. So as I go down that posterior medial gutter, I know I'm not going to damage the ulnar nerve. So the biggest risk with elbow arthroscopy is always knowing exactly where your neurovascular structures are, because we don't want to ever cause any type of nerve injury, which have all been reported with elbow scopes.
Right. So again, big things, especially in your rheumatoids, you're doing mostly the synovectomies. You want to make sure you get into the medial lateral gutters, clear all the synovium out, because again, that's kind of where the pathology is. Versus again, some elbow arthritis, you're going to try to debride those osteophytes. You're going to try to remove those osteophytes, maybe remove some of those loose bodies, the synovium, and maybe some of the capsule if need be. And another thing you also mentioned, that if they can't flex to greater than 90 and you're going and you're doing a release, that you should probably open up and decompress the nerve, because as they start to regain their flexion, they can get a tardy ulnar nerve palsy just due to the nerve being in the groove so much.
Yep. Nerve injury is the scariest part about elbow arthroscopy. So you always want to know where the nerves are. And so even if someone has a subluxating ulnar nerve, that is not a contraindication to elbow arthroscopy. You just need to know where the nerve is. And if there's ever a question, you can always do a small medial incision to identify and protect the ulnar nerve, put a vessel loop around it. Then as you're putting in your medial portals and working in the back, you know exactly where the nerve is. Similar with the radial nerve in the front, I use a switching stick a lot as a retractor. So you can have your kind of standard proximal anterolateral portal, which is just proximal to your lateral epicondyle. You can make one even higher, about 2 centimeters higher, and you can come in with a switching stick down from the top, and then you can use that to retract the anterior capsule anteriorly. So it helps tension things, it helps increase your working space, and it protects your radial nerve. So as you're doing your synovectomy or capsulotomy in the front, you're lower risk of damaging the radial nerve because you have a big metal switching stick in there protecting it.
Yeah, perfect. And so in what cases, because we always read about or hear about the outer bridge Kashiwagi, I might have mispronounced that procedure. So when do we use, I guess, number one, what is it? And then in what cases would that be indicated?
Yep. No, you nailed it. And because it's a mouthful, we'll often call this the OK procedure. So outer bridge Kashiwagi is a mouthful for anyone. So we'll say add an OK procedure. So this is primarily for in someone who their entire coronoid fossa and olecranon fossa is full of osteophyte. So if you see a healthy elbow, normally that bony bridge is 2 or 3 millimeters. And in some of these arthritic elbows, you'll see that both those fossas are completely full of bone. So it might be 10 to 12 millimeters of solid bone. And it can be sometimes hard to know how much of that bone do we have to take away to say that we've fully debrided it. So the OK procedure, which you can do open or arthroscopic, is you drill this fenestration between the two fossas. And so you go from the back, and I'll usually start with a guide wire. So we'll put it right in the middle, and you can bring in a mini C-arm to make sure you're centered. And then I'll go over it with a ACL reamer. So you put a guide wire from back to front. I'll usually have some sort of a retractor in the front. You could use the shaver, or you could use a Cobb elevator just to catch that guide wire to protect your neurovascular structures. And then you come over the guide wire with a cannulated reamer, like an ACL reamer, and you can make a 10 millimeter fenestration with that. Then you can come in with a high speed burr, and you can contour the olecranon fossa and the coronoid fossa back to where they're kind of disc shaped. And that's going to make room for your coronoid and your olecranon to go into flexion and extension. So it helps get rid of those osteophytes and get a better assessment of how thick is that bone between the front and the back. And it also, that fenestration creates a channel for joint fluid to flow back and forth. So even that, patients can feel some relief, because it's the compartments are then communicating again instead of being shut off by all the osteophytes. So the final images will look like those on the bottom, where you might have a 15 millimeter wide hole. And as long as you keep the medial and lateral columns and the spool intact, there's a very low risk of fracture with that. I think that the key is to make sure that you stay within that medial and lateral column, and then you're not going past the spool at the bottom of the olecranon fossa so you're not risking fracture through your distal humerus.
Yeah. And speaking of columns, how we read about like the column procedure, how often are you just doing something with one column? And then I guess what is because we have some interns on here that are listening and have no idea what a column procedure is. What is that? And then
this is what
how often are actually doing it?
This is what we did before arthroscopy. And so you're basically doing a medial and lateral approach. So rather than a posterior utilitarian approach, you're doing separate medial and lateral incisions. So on the medial side, first you will find your ulnar nerve, and then you're basically working anterior and posterior to the distal humerus to get into the joint and release capsular contracture and take out osteophytes. On the lateral side, like this top image, the key is to protect the lateral collateral ligament. So you'll make a lateral sided approach, and then you leave a window like a triangle in the middle to protect that LCL complex. You can come over the top, and you can keep safely releasing the capsule until you see cartilage. So you can get right into the joint. At that level, the brachialis is protecting you from your neurovascular structures. So you can develop a plane between the brachialis and the capsule all the way down to the joint to fully excise the anterior capsule. And then you're looking right at the coronoid fossa. You can be looking right at the tip of the olecranon. In the back, you go posterior to the ulnar nerve on the medial side, posterior to the LCL complex on the lateral side, and you lift the triceps right off the distal humerus. and then you can get directly into the olecranon fossa, so you can clean out any scar tissue or osteophytes. You're looking right at the tip of the olecranon, so you can see the tip of the olecranon deep to the triceps attachment, and you can clean that off with a rongeur or an osteotome. So I usually do the column procedure more often in post-traumatic cases. And it might be because you're going to be removing some hardware, anything. Sometimes those posterolateral plates can be symptomatic. Sometimes the olecranon plate can be symptomatic. If the hardware is not in the way, I'll usually leave it. If you're doing a hardware removal with it, you want to do your releases first, because then you can manipulate a little bit with the hardware in before you take the hardware out. You don't want to take the hardware out and then manipulate it and fracture through a screw hole. That will really ruin your day.
Yep.
And so I do the open column procedure more frequently in the setting of post-traumatic arthritis, where we're going to be taking out hardware. And when I do it, I usually go both sides. So I go medial and lateral, because I'll start on the lateral side, but it can be hard to get all the way over the medial side in the front and the back. And so when you do it open, you can actually look straight across the elbow, under the brachialis in the front, and under the triceps in the back, to make sure you've got rid of all those soft tissue adhesions.
Perfect. Thank you for explaining that so elegantly, much better than I would have explained it.
I don't know about that. Oh, and then go back one slide.
Yeah,
your last point is great. So when people can't flex past 90, the posterior band of the MCL gets very tight. And so you're going to do an open ulnar nerve decompression, and then the posterior band of the ulnar collateral ligament sits at the floor of the cubital tunnel. So if you've got their full extension back, but they're still tight in flexion, if you just excise that posterior band of the MCL, so you can take a 15 blade and you cut out a little rectangle of tissue right at the base of the cubital tunnel, you're taking out the posterior band of the UCL. And once you do that, they'll get their full flexion back. So that's often a test on the OIDI and the boards too, that what do you need to release? If they have a contracture and they can't flex past 90, it's the posterior band of the medial collateral ligament or posterior band of the ulnar collateral ligament. Once you release that, that will give them back their full flexion.
Yep. And I'm pretty sure I not on the boards, but in my practice questions, I saw that exact question.
Yeah.
So perfect. Thanks for bringing that up. And a couple other procedures. One is interposition arthroplasty. And I feel like we've had a couple of patients, at least in my residency, that we had to do this on. Can you explain a little bit what this is, and then which patients should get this interposition arthroplasty?
Yeah. So we try and avoid total elbow arthroplasty in a young patient almost at all costs. The most common reason somebody now would need a total elbow when they're young is going to be post-traumatic arthritis. And so by the time they get to me, they've probably already had 3 or 4 elbow surgeries. So they probably got fixed. Maybe they had a revision. They've probably had some sort of a release. And now they have an arthritic elbow and they're in their 40s. If you do a total elbow on that patient, number one, there's a much higher complication rate, much higher infection rate because they've had previous surgery. They have more soft tissue contracture and the anatomy is distorted. You give them a total elbow and they're young and active, so they're going to try and get back to some high level activities. So there's a very high rate of aseptic loosening over time, much higher rate than in the knee. And it's because the bone is smaller, the soft tissue mantle is smaller. You have to cement a total elbow arthroplasty. We haven't figured out how to do it press fit yet. And there's such a wide range of motion of the elbow that the constraints that bone cement interface can cause loosening over time. So the concern is you do a total elbow in a 40-year-old, and within 6 or 7 years, it comes loose. Well, then you have to revise it. In each revision, there's going to be more scar tissue and more bone loss. So at 47, you're revising it. Then you're revising it again at 55, and then again at 62 or 65, and you're going to run out of bone. And so then it becomes left with a tumor prosthesis, or you have a nerve injury, or they get an infection. And then the treatment of that is to take everything out, put in an antibiotic spacer, redo it all. They're losing more bone. At some point, they're going to end up with an arm amputation. We really try and avoid total elbow arthroplasty in young patients at all costs. If that's their last resort and they're miserable, then that's what we'll do. So another option for somebody that has mid-range pain with an arthritic elbow is interposition arthroplasty. So an interposition is where you're going to put some piece of tissue between the bones in the elbow. That could be the anconeus. It could be an allograft Achilles tendon, allograft fascia lata. It could be dermal allograft. So if it's primary ulnohumeral, you will line the distal humerus with tissue, some sort of allograft or the anconeus perhaps, and you can put drill holes across the distal humerus from front to back and then tie it down and then close them up. So you're basically just trying to open up that joint space with some sort of interposition to try and give them some pain-free motion. If it's radiocapitellar, you can excise the radial head. You can release the anconeus distally off the ulna, and you can roll it up like a burrito and stick it right in that radiocapitellar joint to maintain that space. If it's ulnohumeral, you usually have to release the lateral collateral ligament to gap the joint open, put in your interposition, and then repair the lateral collateral ligament back on the way out. So it maintains their joint, it maintains their normal joint architecture. It prevents an arthroplasty with metal and cement and plastic, and they can get back to activities as tolerated. So with that, they still might not get back full flexion and extension, but if you can give them a functional range of motion that doesn't constantly hurt, that can last a long time. And it doesn't burn any bridges to maybe needing a total elbow 10 years later.
Right, perfect. You can help bridge that time. And again, these are going to be for younger patients that we don't necessarily want to do a type of arthroplasty on because, again, doing arthroplasty in a younger patient may not last X amount of years. So only a certain amount of years it can last, as well as high rates of aseptic loosening, things of that sort.
That's right. And so I think like on exam questions on the OIDI or maybe on the boards, on the OIDI for sure, it's going to give you a scenario where somebody has bad arthritis and it says they're going to have mid-range pain. So they won't have the last 20 degrees of flexion and extension, but it will say they have mid-range pain and they will have failed everything else. It'll say they've failed injections, bracing, therapy, and they've failed a scope and they still hurt. And they're going to be young. So they're going to be in their 40s. And so in that patient, total elbow arthroplasty has risk of long-term failure. So an interposition arthroplasty is a good bridge for that young arthritic patient with mid-range pain. If it's a patient in their 70s that either has post-traumatic arthritis, osteoarthritis, rheumatoid arthritis, they failed conservative treatment, then a total elbow arthroplasty is a good option. But for somebody in their 40s, we want to try and avoid that.
Yeah, and you just perfectly transitioned yourself into talking about total elbow arthroplasty. We've kind of gone down the spectrum here of debridement from less invasive to some more invasive, and now talking about putting a little bit more hardware in there. And so just a little bit of, can you just kind of give a little bit of background, just a high yield on total elbow arthroplasty that we need to know, especially those that are taking their boards in OIT, and then which patients it's going to be indicated for, which you actually just explained a little bit.
Yeah. And so total elbow arthroplasty is really a hinge joint. So you have a cemented humeral component, a cemented ulnar component, and then there's a polyethylene bearing in between. Highly constrained ones, which just function as a hinge, have a high rate of aseptic loosening, and it's because of the stress that's placed on that bone cement interface. So now most designs are a sloppy hinge. So it's still a hinge joint, and usually most of them will link together in some way. So there's a bearing that will link the two. And so they'll flex and extend, but they'll have a little play into varus and valgus as well. And so that little bit of play takes some of the stress off that bone cement interplace to decrease the rate of loosening. There's a couple elbows designed that are unlinked. They're technically harder to put in because you need to maintain the medial collateral ligament and lateral collateral ligament. The hinged ones, you can take the MCL and LCL out because it's a hinged implant and it doesn't matter. They do have isolated radial head replacements. In Europe, they have hemiarthroplasties or unicondylar arthroplasties. Most of these are off-label in the US, but you can still do them. If you have severe radiocapitellar arthritis, You could do a radial head replacement if they get arthritic changes on the capitellum. You could do a radiocapitellar arthroplasty like on the bottom left. You could do a hemiarthroplasty like on the right if they've got good contour of their ulna. In those cases, you would leave the collateral ligaments intact or repair them back to give stability to the elbow. The hinged ones you can take, there's different approaches. You can take the triceps off. It's better if you can leave the triceps on, then you don't have to worry as much about triceps failure with the total elbow arthroplasty. And I think the main indications for those are going to be older patients, probably meaning 70 or older, that have bad arthritis with mid-range pain and everything else has failed. So they've failed cortisone injections, anti-inflammatories, bracing, physical therapy, and they're miserable. Total elbow arthroplasty in that patient population is a really good surgery because they're going to be less demanding on their elbow than you or I are. And they just want to function. They're not trying to get back to sports or heavy weightlifting or things like that. The other place that I probably do it the most now is comminuted fractures in patients over 70. And so if somebody has a dusted distal humerus fracture and you get a CT scan and it's in 12 pieces, it's going to be hard to put that back together, hard to get it to heal, and then try and maintain some range of motion in that patient. So a comminuted distal humerus fracture in somebody over the age of 70 is a very good indication to go straight to a total elbow. You can replace their elbow. You only have to immobilize them for a week or a short period of time, and you immediately get them moving. So they can maintain their motion and function probably better and faster with a total elbow than with a complex reconstruction with plates and screws.
Perfect. Yeah. And then also the weight bearing, it's like a 2-pound lifting restriction, right? Or over, you can't lift more than a certain amount of pounds after once you have a total elbow, which plays into what you were just talking about being useful in less demand older patients that don't necessarily want to go back to the gym and exercise.
Yep. Yeah, and it's hard because we'll tell them try not to lift over 5 pounds repetitively on a daily basis, but 5 pounds is like a half gallon of milk or a carton of juice. And so 5 pounds, 10 pounds is not very much. And so I'll try and tell them, try not to be too hard on it. Try not to lift stuff too heavy. If it hurts to go for a gallon of milk, then that should be your max, because the harder they are on it, the quicker it can wear out. And if they can have a functional elbow and they can do all their ADLs and they can get back to the activities that they want without much impact, then it's a great option. If they're trying to get back to, like you said, weightlifting, sports, a lot of even yoga with a lot of weight bearing on their hands, then there's probably better options than a total elbow.
Yeah. And how often are you doing just kind of those isolated procedures? I've seen some revision arthroplasties in residency, but I don't think I've seen like just a isolated radiocapitellar arthroplasty. Are those really as common, or is it more just these are just one of the options that you have?
They are not one of the options that you have. And I think some of these implants are off label in the US, but you can still do them.
Yeah.
Just tell your patients that it's off label. I think if you look at like the anconeus interposition, that the drawings at the top, that's more common, because if you have a young patient who's in their 20s or 30s and they have a very comminuted, dusted radial head fracture, you try and put that back together and it falls apart. Well, then your options really are resection. But if you do a resection, they might get shortening of their radial column, and that might lead to ulnohumeral arthritis over time. So then you could do a radial head arthroplasty or an interposition. The problem with a radial head arthroplasty, there's a high rate of loosening if you just put in a radial head implant. So the interposition arthroplasty is a good option for radiocapitellar problems when you're missing a radial head. And so you take the anconeus and you fold it up like a burrito or an anchovy, and you tuck it in between the radial head and the capitellum, and then you repair or reconstruct the lateral collateral ligament over the top. And that maintains the joint space, that radiocapitellar joint space. Once the LCL heals, they have a stable elbow, they can get back to doing everything. They can get back to weights, sports, martial arts, everything. And so that's probably a better long-term solution than some sort of a metal arthroplasty in a 20 or 30-year-old who, has another 50 years to live with that elbow.
Yeah, perfect. And Dr. O'Brien, again, I thought this was a great overview and well in depth on elbow arthritis, because we talked about many different causes of elbow arthritis, what they present like on physical exam. We talked about the different treatments, talked about NSAIDs, we talked about injections, and then we also talked about a wide scope of operative treatment options, from debridement to column procedures. We talked about the OK, adding on the OK procedure, because I don't want to pronounce the whole thing right now, as well as arthroplasty. Anything else that you think the people listening to this should know or kind of take away when we're talking about elbow arthritis?
I think you really have to just individualize your treatment options to each patient and ask them what their goals are. So I've had patients that have come in with a painless contracture from arthritis, and they want to know what it is, but then they're okay living with that. And they can say, well, I can't extend my arm all the way, but I can do everything I need to. And I'll say, great, live your life and be happy, and call me if it gets worse. Or they might be happy with a scope debridement just to help relieve the pain and pressure in their elbow, even if they don't get back full motion. And so you really want to talk to them about what are their goals? How much is this affecting their quality of life? Because it might be that medications are enough, might be injections are enough. Maybe they need a scope. And if they're really miserable, then you start thinking about more reconstructive options. And a lot of people are afraid of the elbow for surgical procedures. And the key is just remembering your neurovascular anatomy. So as long as you remember where the ulnar nerve, radial nerve, median nerve are, where the arteries are, as long as you don't damage those neurovascular structures, elbow surgery can be very safe, very fun, and very rewarding for the patients.
Dr. Ryan, it's been a pleasure having you on. I'm so glad we finally got to make this happen. I learned a
Thank you,
lot
Cody.
just
Thank
talking
you
to you.
so much. This is a real honor. I really appreciate it.
Of course. You're more than welcome to come back anytime. For those that are listening, thanks for listening. We hope that you enjoyed another episode. Please go leave us a review. Let us know how much you enjoyed this episode and how much you learned, because I know I learned some stuff. And I already took my board, so I know there's a lot you can learn too.
Nailed it.
Yeah, there you go. Nailed it. All right, everybody. Have a good one again. Thank you so much, Dr. Brian.
Thank you, Cody.